Hi friends, it's Corey from the Midwifery Collective of Essex County, and this is what my whole face looks like. Those of you who have had a chance to meet me in person will not have yet had a chance to see this part of my face. Thanks so much for tuning in tonight. I hope that you'll enjoy our discussion. I hope that people will have lots of questions and that engagement will be high. This is my first time doing a Facebook Live video, so I'm super excited, a little tiny bit nervous. Still getting used to this kind of technology. So if there are techie kind of glitches, apologies for that in advance. I do want to start out by saying that none of the information I'm going to give you tonight is meant to replace the advice of your healthcare provider. It's meant to be educational and informative only, maybe a little entertaining, hopefully a little entertaining, but if you do have questions about your specific health, then I would recommend that you bring them to your primary health care provider. I should also give the disclaimer that the bulk of the information that we're going to discuss today is very specific to Ontario and probably also specific to the region of Windsor and Essex County, although midwifery looks familiar in many places in the world, so it may also apply to you. I would look into local regulations in the community that you're joining me from if it's not Windsor, Essex County, and welcome. If it is or isn't Windsor, Essex County. Thanks so much for joining me. I'll tell you a little bit about myself. My name is Corey. I'm a registered midwife. I have been living and working in the Windsor and Essex County region since, since September of last year. Prior to that, I had been living and working in Hamilton, Ontario. I graduated from McMaster University in 2017, so I'm not quite a baby midwife anymore. Maybe I'm toddling my way toward childhood, hopefully, but I'm still new enough in the career that I'm still pretty new in the career, is what I'm saying. I'm not brand new, but I'm not yet old hat, if that makes sense. The Midwifery Collective of Essex County is a group of 6 brilliant women who provide pregnancy care and postpartum care for folks having low risk normal pregnancies during their pregnancy, their labor, their delivery, and their postpartum. We are we have offices in Windsor and in Essex County as well, out in Leamington, so we can provide care to women across the whole region, and we provide you with personalized pregnancy care 24 hours a day, 365 days a year, and as some people are already showing up in the comments to attest, the care that we provide people often are quite satisfied with. We do have a lactation consultant who works with us as well, and she provides care identifying breastfeeding issues, giving you support with those breastfeeding issues, and can also help to, connect you with other resources in the community. So I'll say first that if you're watching us on Facebook, which the people that are chatting you will find our contact information. If you're not already familiar with how to get a hold of us, you'll find it on our Facebook page. If you're watching us on YouTube, then hopefully that information is going to be just below my face here. I really hope that if you are liking what you see, that you'll tune in every week. It's our plan to start doing these on a weekly basis. And so be sure to like our Facebook page, follow us on Instagram, make sure to like and subscribe on our YouTube, which is just below my face, probably. And for those showing up to give me compliments about the care that I provided, thank you so much. I'm really a very passionate midwife. I love the work that I do. I love providing care for people. I love health teaching. It's my favorite thing to go into a labor where somebody is struggling to stay ahead of their contractions and giving them something to grab onto to get them to a vaginal delivery. So what I wanted to talk to you about today, and people please feel free to start asking questions in the comments. I'm watching them as they scroll below my face. And so I will get to all of the questions as they come up, but I thought I would come with a little bit of material to talk about in advance, and something that has been something that I think about and talk about a lot is common myths that exist about midwives and midwifery care, where I find I'm providing education again and again and again to people who just aren't familiar with pregnancy care, or who just aren't familiar with the kind of care that midwives provide. So I've come with a list, but I'm also going to interrupt myself anytime I see a question that deserves an answer coming up in the chat there. And also I would love to talk about genetic screening and what that looks like in Ontario as well. So I think probably the most common myth about midwifery care is that midwives and doulas are the same, provide the same care. And I will say that there is some overlap between the care that midwives and doulas provide, but there's a really big and important distinction. So doulas and midwives both are very skilled at providing labor support, and we know that that one-to-one labor support for people during their labors can help to get to a successful vaginal delivery, happy, healthy baby, happy, healthy mom, which is, of course, what everybody wants. The main distinction between doulas and midwives is that midwives have quite a bit more training than doulas to manage the clinical picture as well. And so midwives take care of women during their pregnancy as their most responsible provider, or their MRP, that's a term that we use, and are managing the pregnancy clinically. So doing diagnostic tests, sending folks for ultrasounds, monitoring the progress of the pregnancy, listening to the fetal heart rate, making management decisions about the pregnancy, and then again in labor, where there's a wide range of things that support that doulas provide. Some are exclusively labor, some do labor and postpartum as well, but doulas don't step into that role of clinical manager in the same way that that midwives do. So that's probably I would say the most important distinction between doulas and midwives. It's also important to note that, and this leads me into number 2, that midwifery care is covered by the Ministry of Health for all eligible Ontario residents. And the difference between midwives and doulas in that sense is that doulas are a service that you would pay out of pocket for. So, another pretty common myth is that you need to have a referral in order to get into care with midwives, which just isn't true. So you can visit our website, midwiferycollective.ca, and we have an intake form on our website. Let me make sure that's correct, because yes, midwiferycollective.ca, I always just Google it and follow that link. So we have an intake form directly on our website. You can also call the office if you're interested in getting enrolled with midwives, and we can take you on as our clients as soon as you know you're pregnant. So what often can happen in the midwifery world is that we get full up of clients, and then we simply aren't able to accommodate people coming in later in their pregnancy. So we really do encourage you to, it's kind of a running joke, you pee on a stick, find out you're pregnant, you call your midwife, and then you call your partner to tell them. And I wouldn't say that you have to call us that early, but yeah, you can self-refer to a midwife at any time in your pregnancy, and the sooner you do it, the higher the likelihood that we'll be able to take you into care. The reason for that, of course, is that midwives have a limited number of clients that we can care for per year, and once we fill up, we are starting to compromise the quality of care that we can provide when we have lots and lots of people on our roster. Of course, that happens because we come to you in labor, we stay with you in labor, and we provide quite comprehensive postpartum care as well. And so so that is another myth about midwifery care that I wanted to share with you. I'm just referring to a list over here. So generally in pregnancy, most people are, or many people are, seeing a family doctor for the first sort of 20 weeks of pregnancy. And then once you hit 20 weeks, it's kind of, you're crossing a threshold into actually being an obstetrics patient. And so you can sometimes enroll in pregnancy care at that 20-week mark, but again, if we're full, then it's a good plan to just try to get to us earlier. So once you know you're pregnant, you can get in touch with our office, and we will do our best to get you into care. What else? Some people wonder about seeing a midwife and a doula, or seeing a midwife and an OB at the same time. There are certain instances where a midwife would involve an OB in your care, either as a consultant or as a transfer of care, but But for the most part, if you're having a low risk, uncomplicated pregnancy, then you just see your midwives. There's no need to see an OB, and midwives will provide you with the same kind of ultrasounds and tests and things that an OB would provide you with. Of course, if your pregnancy does become a little bit high risk, then once you're in midwifery care, we stay on in your pregnancy in a supportive role, and you don't lose your access to midwives. We want to be there at your birth for you. Once you're not pregnant anymore, you're not having a high-risk pregnancy anymore, and so your care gets transferred back to midwives, and on we go. Elizabeth has asked a question: what happens in cases of loss, and what does the aftercare look like? And I would say it depends on when during the pregnancy you experience the loss. So perhaps something that we don't talk about enough is that about 25% or 1 in 4 pregnancies will end in a miscarriage, often early in the first trimester and often before you even knew that you were pregnant. So we do sometimes have folks get in touch with us and get rostered on our caseload as clients who will come into care, who then go on to miscarry before they've even seen us. And in that case, the management almost exclusively happens with either the ED doc or your family doctor, or perhaps an obstetrician who manages sort of the aftercare of that miscarriage, whether it involves medication or something like that. When you have a loss later in pregnancy, so after 20 weeks, for example, we as midwives work together to make space for a midwife to be sort of a dedicated care provider for you during that, depending on what it is that you're looking for from us. So often we will come to you if you are having an induction to if you're having an induction of labor, for example, to deal with that loss, then we will come to you and we will be with you in a supportive role during that process. And we can also help to be like I want to say like a liaison between you and hospital staff, and a known face, or most of a face these days, in the room. And then the aftercare is whatever you need from us. And so we really sort of open the door and leave it open for what you want from us. If you want us to come and see you in your home, then we'll do that. If you feel comfortable to come and see us in clinic at some point, then we'll do that. And we manage your postpartum symptoms like your bleeding, engorgement, milk regression, and things like that. We help you to manage that in whatever capacity you feel like you need from us. I feel like people experience losses differently, and so some people would be interested in having all the support, and some people really are people that go inside and process things internally on their own and don't look outward for that kind of support. And so it's really, we want to provide the care that is going to work for you. So sometimes it simply looks like, making sure that you know what the resources are in the community. If you want to join like a postpartum, an infant loss support group or something like that, we try to help you get connected with that. But really, it depends on what it is you're looking for. That was an excellent question, and I stumbled through it a little bit because it's a tough question to answer, because it's a hard thing to talk about. We never want to talk about pregnancy losses ever, but I really think that it's an important thing for us to address and be able to sort of look in the face as, a potential outcome anytime you get pregnant. Not what we want, not what we expect, but certainly a possibility, no matter how remote. Great question. I'm going to jump back into my list. We were talking a little bit about if you have a high-risk pregnancy, so you would see an OB and a midwife together. The midwife would be more in the support role, while the OB would be providing your clinical care, and then often you're transferred back to midwives in the postpartum. And we pick up that postpartum piece for baby as well, so coming to see you at home, monitoring baby's weight, providing that breastfeeding support, and then seeing you for that full 6 weeks course of care. Some people, so this is a big one. Some people think that if you're using a midwife in your pregnancy, that you have to have your baby at home. And that, while we hope that everybody who is eligible to have a baby at home would consider doing so, it's absolutely not true that it's required for you to have a baby at home if you have midwives. We definitely We have a lot of good research that tells us that when you're appropriately risked and when you are attended by midwives who have emergency skills training and who bring emergency equipment to your home as well, when you're in a community where midwifery is overall well integrated into the community, we know that home birth is just as safe as hospital birth. And so we really want to protect that for the folks who want to have their babies at home. But so much of labor is psychological, and so if you're not someone who's going to be comfortable birthing at home, then we're not in the business of talking you into doing that. We want to make sure that you're where you're comfortable having your baby. And lots of people feel like I feel like my labor would go fine, but just in case, I want to have the access to the services of people who can deal with emergencies. And I think the big one that people are thinking about is, what if I need a C-section? And so definitely we want you to be in an environment that's comfortable for you when you're having your baby. So you can have your baby in the hospital with midwives. In this region, we deliver, or we can help you deliver your baby at Windsor Regional Hospital and also at Erie Shores Health Care in Leamington. So I would say that all the midwives at this practice love home birth, but it's really about you and what you want for your birth. And so we'll support whatever choice you make. Another big one is that if you have care with midwives, you're not able to have an epidural in your labor. And this is not exactly true, but is true-ish in some regions. So there are some hospitals in Ontario who, if you are choosing to have an epidural in your labor, then your care gets transferred to the obstetric team. And so the midwife stops being your most responsible provider during that labor. In Windsor and Essex County, that is not the case. So at both hospitals, if you are choosing to have an epidural in your labor, then the epidural part of the labor is then managed by anesthesia and nursing together, but the labor itself continues to be managed by midwives. And so you don't lose the care of your midwife, you don't lose the management of your midwife, and most often you go on to have a vaginal delivery with your midwife, just with the help of nurses. But in some regions in Ontario, definitely if you're getting an epidural, then that might look like a transfer of care. Some people wonder, can I have midwives if I've ever had a C-section? Or some people think if I've had a C-section, I can't have midwives. Also, that is not true. So we do a lot more than labor care as midwives. We provide care for you during your pregnancy. We also provide care for you in the postpartum. And so if you have had a C-section, that's only a part of the care we provide. So lots of folks these days are thinking about having a trial of labor after cesarean, or a TOLAC, which we always hope will lead to a vaginal birth after cesarean, which is a VBAC. And certainly if that's your plan, then we can make that happen for you. Some people in their pregnancy after having had a C-section would want to have another C-section, and so we can organize a visit with an OB to get that set up for you while we provide your pregnancy and your postpartum care. So it's a transfer of care for the C-section and then transfer back to midwives in the postpartum. So absolutely, yes, you can have a midwife for your pregnancy care even if you've had a C-section in the past. I think that's all the myths, the pervasive myths that I have to talk about midwifery care. So if anyone has questions, you can feel free to start asking questions in the chat there. I was also planning to talk a little bit about I feel like Jess did a good job talking about home birth. I know Diane's going to be talking about the midwifery scope of practice. So I don't want to do too much overlap, but basically midwives provide care to people who are having low-risk pregnancies during their pregnancy, during the labor and delivery, and for the 6 weeks after baby's born, for mom and baby both. And in some instances, when your pregnancy becomes a little bit high risk, we still can continue to manage it, sometimes in conjunction with an OB. Most of your postpartum care happens in our clinic. Most of your prenatal care, happens in our clinic. Some of your postpartum care is at your home. Some of your postpartum care is in clinic as well. And some is in the hospital, depending on the case. So I think I'll shift gears a little bit and I'll talk about genetic screening. So prenatal genetic screening is something that's offered to all pregnant people in Ontario. The sort of routine screening is something called EFTS, Enhanced First Trimester Screening. And this is an ultrasound and a set of blood work done on the same day or within 24 hours. The ultrasound is looking for something on the back of the baby's neck called the nuchal translucency, and it's just like a little fluid-filled bump on the back of a baby's neck. And then the blood work looks at some of the hormones and proteins in your blood that the pregnancy and the developing placenta are starting to make. Genetic screening tells us a little bit about the risk to your pregnancy of certain known genetic conditions like Down syndrome or trisomy 21, trisomy 18, trisomy 13. It's not considered a diagnostic test, so the result that you get from a genetic screen is 1 in 20,000, 1 in 10,000, 1 in 500, 1 in 10. And what that means is if there are 20,000 of you, one might have a baby with Down syndrome. If there are 10 of you, one might have a baby with Down syndrome. A positive result is any result greater than 1 in 350. And so that means if there were 350 of you having the same pregnancy, one of those pregnancies would be affected by Down syndrome, for example. A positive result qualifies you or makes you eligible for something called NIPT or NIPS, depending on who you're talking to about it, non-invasive prenatal testing or non-invasive prenatal screening. Of course, the difference between a screen and a test is that a screen gives you a risk value, a test gives you a diagnostic result. So I prefer to call it NIPS because it's still not considered diagnostic. The NIPS is one single blood test, and the blood test isolates the placental DNA in your blood. So, of course, DNA is it's our blueprint for our bodies. Every body has 26 pairs of chromosomes. You get 13 from your mom, 13 from your dad, 13 from the egg, 13 from the sperm, and there are 25 pairs and then 1 pair of sex chromosomes. And so when we're doing NIPS, what they're doing is they're looking at the placental DNA and they're doing a process called karyotyping. This is probably way more technical than everybody's interested in, but I'm a big nerd, so I'm gonna just keep educating you. So they do this process called karyotyping, which is where they actually line up the chromosomes pair by pair by pair. Pair number 1, pair number 2, pair number 3, pair number 4, and so on. And they count the pairs to make sure there are 2. And they can also look at how the sex chromosomes are organized. So do we have 2 X's, which indicates a girl baby, or do we have an X and a Y, which indicates a boy baby? And then they're also looking for anomalies. So they're looking for sets of chromosomes where there might be 3, and we call that a trisomy. Probably everyone has heard of the term Down syndrome. The other name for Down syndrome is trisomy 21, which means there are 3 copies of the 21st chromosome. So there are other trisomies that we sometimes see in pregnancy. I've already mentioned trisomy 13, trisomy 18. We don't talk so much about those trisomies because often, sadly, those pregnancies don't carry to term. So we don't see babies born with those diseases very often. And NIPS is also able to detect sex-linked chromosome anomalies. So we have something called monosomy X, where there's only 1 X chromosome and no Y chromosome. We have things like fragile X. We have sometimes there can be 3 X's and 1 Y, and so there's all kinds of interesting things that chromosomes can do that sometimes impact a pregnancy that sometimes don't. It also looks for micro deletions, which is little parts of the chromosomes that are missing, and it also can find translocations where, for example, on an X we have something that should be over here and it's actually over here and it's reversed. So on one arm it should be here and it's actually on this arm. In any case, often the result from an NIPS is a negative. A negative is something like 1 in 10,000 or low risk. If we have a result on NIPS that is positive, then we recommend one more test before we start to think about making permanent decisions about the pregnancy. And of course, by that I mean considering ending or terminating that pregnancy. So the diagnostic test for chromosome anomalies is called amniocentesis. And amniocentesis is a process where they actually take some amniotic fluid from your uterus through a big long needle, which sounds terrifying, but it's actually reasonably safe when done properly, when done with ultrasound guidance, which is how they do it these days. The reason that NIPS is not considered a diagnostic test is because it's looking for pieces of placental DNA in the maternal bloodstream. And sometimes the DNA that a baby has and the DNA that a mom has are not the same, or the DNA that a baby has and the DNA that the placenta has, are not the same. So there are conditions, for example, mosaicism, where the placenta and the baby actually have different DNA. And so what we want to do is look at baby's DNA. We're not going to go in and take baby's blood, but what we can do is we can have access to baby's skin cells, which are floating around in the amniotic fluid. And so we take some of that fluid and we do that same karyotyping process where we line up the chromosome pairs one by one and look to see if there's any anomalies, like three of a kind instead of a pair and things like that. If we have a positive finding on amniocentesis, it is considered a diagnosis. Generally, at the time when you get a positive result on your NIPS, we're going to refer you to see a genetic counselor. And that's going to be a midwife, it's going to be an OB, it's going to be your family doc. It's going to be any pregnancy care provider who comes across a positive finding on NIPS. We're going to send you to see a genetic counselor to talk about what the next steps are and what your options are. And so I feel like people have a wide range of thoughts and feelings about genetic screening, and it's not actually neutral testing. There's some very important ethical considerations when we start talking about genetic screening. First of all, because we can screen for certain known conditions. So we know that sometimes babies have Down syndrome. We know that sometimes babies have trisomy 18 and trisomy 13 and sex-linked chromosomal anomalies. But we can't use genetic screening to tell us everything that could affect a pregnancy. So it gives us access to some information, but not some information. And when we start thinking about babies with these conditions, the question we're really asking at the end of the day is, what would you do with the information you get from these tests? Are you the kind of person, or is your family the kind of person who would consider ending a pregnancy if you knew for sure that baby had some sort of genetic chromosomal anomaly? Or are you the sort of family that would never ever think about ending a pregnancy no matter what? Or are you somewhere in between? And it's really a spectrum of how people feel and how people think, and I think it depends on your culture, your family culture. It depends on your experience in the world. I think that often your belief system can play into it as well. So it really isn't a test that should be approached with kind of a neutral mindset. As a care provider, I certainly don't approach it that way. My role as a midwife is to give you all the information that you need, but you're the decision maker. And so this decision is a really personal decision, person to person and family to family. And so certainly we see folks who don't do any genetic screening in their pregnancies ever. And then we see folks who want to have all the genetic screening they possibly can. And there's no right or wrong when it comes to genetic screening. It's really just about what information do you want about your pregnancy, and then what are you going to do with that information? And of course, the sort of follow-up to the genetic screening comes in the middle of your pregnancy when we do your 18 to 20 week ultrasound. We're looking at baby head to toe, and often we can see, if there are structural anomalies, if there are certain what we call soft markers, so little small anomalies like little cysts in baby's brain, or sometimes a bright spot in baby's heart or baby's bowels. And those can sometimes point us toward a possible genetic condition, but not always. So, so I would say the EFTS, the NIPS, amniocentesis, plus the second trimester anatomy ultrasound really give us the most comprehensive amount of information that we can have about a pregnancy, given our current ability to know things about pregnancy. Sometimes people come to us later in their pregnancy and they've missed that window. So we do the enhanced first trimester screen, or the EFTS. We do that somewhere between 11 and 13 weeks. And so when people have missed that window, then there's access to another test that can give us kind of similar information called MSS, or maternal serum screen. And of course, amniocentesis we can do throughout most of the pregnancy, although if we're seeing a baby that's severely affected with a syndrome, we're generally trying to make decisions about that pregnancy earlier in the pregnancy, especially if our decision might be, you know, I think I would want to terminate this pregnancy. Thus, in Canada, there's no laws about pregnancy termination under the criminal code, which is different from the United States. The laws about terminating a pregnancy fall under the Healthcare Professionals Act. And so really the earlier in a pregnancy you're choosing to pursue a termination, the less complicated that termination is. The later in pregnancy, the more complicated. And nobody ever wants to talk about terminating pregnancies, so it just becomes an eventuality. It becomes an eventual discussion piece when we are talking about genetic screening. And so my perspective is, let's make sure that we're aware of that. When we take our first step down this road of genetic screening, let's be sure that we're aware that this could lead us to a place where we're actually thinking, do I want to carry on with this pregnancy, or do I want to think about ending it? I think that's all I have to say about genetic screening. I also try to give a similarly thorough talk about it when I'm, you know, seeing people early in their pregnancies, and just really try to provoke people to think about the testing and what it is and why we do it, and whether they want to do it at all. So I can just open the floor up for general questions if anyone has any. We could talk about the heat wave. It's pretty hot out there. I feel like I've covered a lot of different things, but it's been maybe a little disjointed. I tried to, talking about myths of midwifery, like you could ask 10 different people about what is a midwife do, and you're gonna get 10 different answers depending on what people know about midwifery. So that's kind of a scattered topic, but yeah, I'll just let people ask questions if you want to ask questions. I'll go back and talk a little bit about genetic screening. Sometimes people who feel like they would never end a pregnancy, they would want to know, for example, if they're having a baby with a genetic condition, they would want to know about that so that they could get connected with resources in the community. So maybe you're having a baby with Down syndrome and you want to connect with other families who have babes with Down syndrome, or you want to have a chance to do some research about what that might look like for your specific baby. And that's quite reasonable as well. I feel like I have talked that through now. I would welcome you to tell me in the comments if you have had genetic screening or what your thoughts are about it. If there's anything you've maybe heard about midwifery and you always wanted to ask a midwife, hey, is this true? I had a client once say, you know, my friend's mom, who's a nurse not in Windsor, but she's a nurse working in labor and delivery, said I should never have a midwife because she didn't really know why. So she said, do nurses and midwives work well together? And I would say, you know, nurses and midwives are all people, so I feel like we work as well together as we can, and not everybody can get along with everybody, so every so often there can be little personality clashes. In my experience, I love working with nurses, I love working with doctors. I think we're all there for the same reason. We're all there for a happy, healthy baby and a happy, healthy delivery and a happy, healthy family. That's what we want to send out the door. So we sometimes get at that result in slightly different ways, but we all have the same goal. I'm always saying stupid things like teamwork makes the dream work, but actually, like, I really believe that. I think the better we work together, the better care we can provide for our clients and our patients. Monica's wondering, are there any laws in this state requiring any vaccines or the vitamin K shot? That's a pretty broad question. I can talk about it as it relates to brand new babies. And so Ontario is a province in Canada, and we offer and recommend that all babies get vitamin K because we know that some babies are at risk of vitamin K deficiency bleeding. We can't always do a good job at identifying which babies will be at risk. So when we treat all babies as though they're going to be at risk, we know that that saves some babies' lives. Vitamin K is not a mandatory intervention, so babies are not required to get a vitamin K shot, but it is considered in Ontario what we call a standard of care. So it is sort of assumed, unless you tell me otherwise, that you would accept this intervention for your babe. Although in midwifery care, we're still going to be having a conversation with you. Vitamin K is super important because the kind of vitamin K deficiency bleeding that can happen can be hidden inside and around baby's organs and in baby's brain. And as I'm sure you know, if you're having bleeding in your brain, that can cause damage to the brain, which can impact a person throughout their whole entire life and can actually end up leading to a death. And we would never, ever, 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 ever want a baby to die. So while there are no laws, it is a recommendation, and often a strong recommendation, stronger for some babies that are born early or some babies that have a traumatic delivery or a delivery with lots of bruising. But it is recommended for all babies in order to keep the babies that would get sick, that we wouldn't detect that they're sick until it's too late, from getting sick in the first place. Then for vaccines, there are no vaccines administered to babies in the first 6 weeks of life, and that's when my scope of practice expires. So I'm not qualified to talk about anything beyond that 6 weeks. The other medication that we have historically given to babies is something called erythromycin, and this is a mild antibiotic ointment that we put in babies' eyes. It's kind of like polysporin. In Ontario, it has historically been public health law for us to administer this medication to all babies, and recently we were able to amend that law such that we are now only administering that medication to babies that are at risk of eye infection, the kind of eye infection specifically that you would get if there was a maternal chlamydia or gonorrhea infection during the pregnancy. So most babies are not getting that treatment. I hope that answers your question in some fashion, Monica. And I believe that there's lots of information online about vaccines and sending your kids to school, but that's way, way, way beyond when I stopped taking care of babies. So, Tina, you would qualify for postpartum care for approximately 6 weeks after the baby's born, and generally for about the first 2 weeks, we come and see you at home for that care. And congratulations on being pregnant with your first baby. If you're in care with us, I'm looking forward to catching that baby for you. Roxanne says, as someone who hasn't had to use the NICU, would the midwife still look over the baby even when the baby's in the NICU? So when babies are in the NICU, the baby is under the care of the pediatric team or the neonatal intensive care team, so either a pediatrician or a neonatologist. So what that means is the midwife is in the supportive role for baby, and baby's care is being clinically managed by more appropriate, more qualified people, and that would be a pediatrician or a neonatologist. We don't generally come to, thanks Roxanne, we don't generally come to see the baby alone in the NICU, but we will come to see the mom or the family in the NICU if that's where they are, and quite often when babies are in the NICU, moms are in the NICU with their babies. So we do still provide clinical care to the birthing person, even if the baby is in the NICU, so we'll come and see you wherever you are. Sometimes midwives can, because lots of things happen to babies in the NICU. And so sometimes midwives can come with you, can chat with the nurses and doctors for you. I would say in most NICUs, certainly most NICUs that I have experience with, the docs and the nurses are really, really good at knowing that parents are nervous, parents are worried about what's going on with their baby, but also that parents don't have access to a medical lexicon. They don't have access to the same kind of medicalized vocabulary. And so they're really good at taking big concepts and making them into smaller, more digestible concepts for people that aren't trained in medicine. And so while I would say that midwives can come and be like, not necessarily an advocate as much as like a liaison, like come to ask your questions and help make sure that you're understanding the information that they're giving to you. I would say that the docs and nurses that work in NICUs are actually really good at simplifying that for you. I'm just gonna be right back. My cat is making some very alarming noises from downstairs. Sorry, friends, that was the loudest hairball that a cat has ever coughed up in the whole entire history of mankind. So everything is fine. So yes, Roxanne, to answer your question, we're not coming to see baby in anything other than a watching baby get better kind of capacity, but we definitely will come and see the family in the NICU if that's where they are. We're monitoring mom's blood pressure, mom's bleeding, you know, lactation and breastfeeding and all of those things. Good question. What else can we chat about? It's funny, I'm watching myself on my computer and there's like a 3-second delay. So I take a sip of Diet Pepsi and then I look and watch myself take a sip of Diet Pepsi. Monica's wondering, do we recommend that she hire a doula? And if so, is there a doula that we regularly work with or recommend? So it really depends on what you think you're going to need in your labor. Doulas are an amazing and excellent set of extra hands for providing massage and counter pressure, also for showing your partner how to do massage and counter pressure. And I definitely have worked with a lot of doulas who, you know, have really good experience with, I don't want to say hypnobirthing exactly, but just like, you know, constant calming, soothing reassurance and empowerment of the laboring person. So I think that there's definitely a real place for doulas in labor. Our research tells us that when you have the care of a trained labor support person, the one-to-one care of a labor support person, that you're going to have, you know, more satisfaction with your labor process and probably a slightly higher chance of having a vaginal delivery. So personally, as a midwife, I love working with doulas because as a midwife, I'm providing support and I'm also managing the situation clinically. And in hospital especially, that means doing a lot of things like documentation and checking in with nurses and stuff like that. So having a doula at the birth frees me up a little bit to do some of those things. But you are also going to get really great labor support from midwives. And we also will help to empower your partner to provide you with that labor support as well. So it's really about, it's about you. It's about how, like, are you resourced enough to hire a doula, right? I feel like not everybody would be able to afford a doula, so that's an important consideration. And how do you do pain, and how do you do endurance, because labor can be a marathon. And if you feel like having an extra set of hands and an extra person who has training and support to get you through that would be beneficial for you, then absolutely, I think it's great to hire a doula. Yeah, I hope that answers your question. I'm new to the area, so I've only worked with, I want to say, 2 doulas, and I wouldn't say that I've worked closely enough to really make a recommendation. I would say that most people who have midwives choose not to have a doula because you know that you're going to get the support of your midwives. And when you're having like an obstetric birth, it's not that you're not also getting support during that labor, but the nurse that labors with you is probably someone you haven't met before, whereas when you're with midwives, it's a known person with you in your birth. And so we have that sort of pre-existing, I want to say, relationship, pre-existing connection, and we know things about you that maybe labor and delivery nurses wouldn't, like, we have information about you that maybe labor and delivery nurses wouldn't, because we've been following you in your pregnancy as well. So I don't want to knock obstetric births, but I would say most people who have their babies with midwives don't get doulas. And I don't know what it looks like in terms of people having babies with docs and nurses, like what sort of the percentage of people who have doulas in that situation are. I hope, again, I hope that kind of answers your question. I think it's good if you think you need it. I think if you think you can get there with the support of your partner and your midwife, then save your dollars and buy a fancy stroller or something. In terms of having your baby in the hospital, lots of people these days are wondering what are the guidelines about visitors. At both hospitals, you're able to have one labor support person with you. At Windsor Regional these days, you're actually allowed to have 2 visitors, and they can come, they can switch off like every 12 hours or something like that. They both have to be over the age of 18, so not 2 at the same time, but 2 different people who can alternate coming to see you. And that's what that looks like at present. If you do have a doula, if the doula is a registered card carrying, this is my doula card. I don't actually have one, which is why there's nothing there. But if they're a registered card carrying doula, then they come as, they're not there as a support person. So they don't replace your partner. They're there as sort of in a kind of a staff capacity at the labor. So you can have your partner and a doula and a midwife all at the same time. And then a second midwife comes just before the baby comes too, so. And in hospital that happens much of the time, although in Windsor and in Leamington we have great relations with the nursing staff there, and so sometimes we're able to rely on the expertise of the nurses to help us to transition brand new babies instead of calling in a midwife. But at home, we're always 2 midwives. Good question. Good questions, Monica. I'm guessing that you're in Windsor, since you were asking if I knew of any doulas in the area. And I think probably you can just Google Windsor doulas, or ask any of your friends who might have had a baby. Does anyone else have any other questions about midwifery care generally, midwifery care in Windsor, Essex County? The midwives at our group. We're going to be doing this Ask a Midwife every week. We're going to be having a session every Wednesday from 6 to 7. And next week, Abigail is going to be coming to you live to talk about sex and intimacy during pregnancy. So that should be an interesting chat. Get ready with those questions. And as I said before, we are going to be publishing these on, I feel like somehow they stick around on our Facebook page. We're also going to be posting them on YouTube. We've already started posting them on YouTube. So if you have friends who want to know more about midwifery and you don't want to do the work to explain it to them, you can direct them to our Facebook page. You can direct them to our YouTube. We also are on Instagram. I want to say we're at Midwifery Collective. Our website, of course, is midwiferycollective.ca. We have lots and lots and lots of great resources on our website, including links to pre-recorded prenatal classes, links to different resources about pregnancy and the postpartum as well, and our intake form. So if you know someone who's looking for care, or if you're here watching and you're not yet in care, that would be a way to connect with us. Monica is asking if we offer any parenting classes to get ready for birth. So at this time, we're not doing much of anything other than providing sort of the routine care. I'm new to the practice. I have not worked at a practice where we do prenatal classes, although we spend 30 minutes with you every time we see you, with the exception of that first visit with us, which is usually an hour. And during those 30 minutes, we have lots of time to explore some of these things. So we also have lots of really great resources on our website. I'm going to imagine that at some point the world is going to return to something that resembles what was once normal, and you'll be able to find those kind of classes in the community as well. In the meantime, the internet is kind of our best option. And so yeah, there are, on our website specifically, there's a series of 3 prenatal classes. One is about pregnancy, one is about labor, and one is about the postpartum, and they're pre-recorded by a midwifery group, I want to say up in Thunder Bay. So it's midwifery led, so therefore midwifery friendly, and lots of really great and comprehensive information there. And Monica, if you're in care with us or if you're in care with midwives, then we spend time with you talking about these things and helping to get you ready. I feel like one of the things I try to do really well prenatally with my clients is to help them to manage their expectations about what labor might look like. Because actually I keep saying we have research. Midwives are, we're all evidence-based care practitioners, so we look to what the evidence tells us in order to inform how we practice and how we provide care, which is why we make the recommendations that we do. So evidence tells us that when you have approximately the kind of labor that you were expecting, no matter what it looks like, when you have kind of the birth experience you were expecting, then people report more satisfaction with that. So what that means is, if you go into your labor with the expectation that sometimes bodies just don't do a great job of birthing babies, and sometimes we need to have C-sections. If that's your expectation going in, even though our hope is always for a spontaneous vaginal delivery, but if you go in with the expectation that sometimes that process doesn't go 100% as planned and you do end up having a C-section, if you already had that expectation, then you're less likely to be disappointed about having a C-section. So I feel like one of my roles as a midwife is to really work hard to help people manage their expectations about labor, and education is one really great way to do that. So we've just posted some information about the VON having some online modules as well. That is a ghost in the machine working in the background. I wonder if it is Andrea, who's the owner of the practice, who's joined in to watch and just sharing that resource, or if it's one of our other lovely people. But that would be a great resource too. Yeah. Good question, Monica. And I don't think actually that it's ever too early in your pregnancy for you to start thinking about labor and what you want your labor to look like, and asking questions and getting prepared. And there's also lots of really great resources online about how to sort of physiologically prepare your body for the best labor outcome. And spinning babies is a really great example of one. People often also do lots of work in pregnancy with a chiropractor, with a massage therapist, even with a pelvic floor physiotherapist, to really get their bodies sort of in an optimal condition, or optimally primed to have a successful spontaneous vaginal delivery. So Great question, Monica. Great resource provided, Midwifery Collective of Essex County, whichever ghost in the machine is providing that information. And my husband, of course, is walking back and forth in the background there. Was there another question that I missed? I don't think so. This has been really fun. I'm glad that people tuned in to hang out with me for a little bit. I hope that you found the information entertaining and informative. Once again, none of the information that I've given you today is intended to replace the health advice of your family doc, your obstetrician, or your midwife. It is meant to just provide you with some solid information from a midwifery perspective, which can sometimes look a little different. We look a little differently at the world, I think, than some care providers. So from our perspective. Once again, midwiferycollective.ca is our website. Our contact information is going to be probably below my face on YouTube, or somewhere on this Facebook page, or somewhere on this Instagram page. It's certainly on our website. And be sure to tell your friends about Ask the Midwife. We're going to be doing it weekly, like I said, Wednesdays from 6 to 7. Please come back and join Abby next week. She's going to be having a sexy chat about sex and intimacy and pregnancy, and that should be hopefully at least as entertaining, if not more entertaining than I was. Thank you for that compliment, Monica. Thank you again so much for joining. If you're watching us on YouTube, like and subscribe. Follow us on Insta, follow us on Facebook, and you'll be sure to get lots of great updates from our clinic. I'm going to sign off now. Thank you, friends, for joining me. I wish you all a happy, healthy pregnancy, and hope to see you again soon. Thanks, Lily. Take care. Bye-bye.